Good day. Thank you for joining us. You are joining a session that is being coordinated by the Society of Critical Care Medicine on the future of respiratory diseases. My name is Dan Brown, and I am co-moderating this session with Amy Zerba, and we have a distinguished panel to participate today. Starting off will be Dr. Mike O'Connor, who is from the University of Chicago in Illinois in the United States. He is a product of the University of Chicago, where he is professor of anesthesiology as well as internal medicine, where he is the executive medical director of critical care medicine at the University of Chicago. He will be followed by Dr. Alice Gallo, who currently Dr. Alice Gallo Di Maria, who is from the Mayo Clinic, joining us from Brazil. She practices in Rochester, Minnesota, also in the United States, where she is an assistant professor of medicine. And finally,
and then we will wrap our session up with Dr. Laurent Burchard, who is an intensivist and director of the Interdepartmental Division of Critical Care Medicine in the University of Toronto, Canada. And he's also the Keenan Chair in Acute Respiratory Failure and Critical Care Medicine at St. Michael's Hospital, where he leads the Center of Excellence in Mechanical Ventilation.
I was asked to talk about phenotypic heterogeneity and ARDS and implications on its implications in COVID-19. This is my COVID-19 team at the University of Chicago. These are the physicians from anesthesia and critical care and pulmonary critical care who took care of all of our COVID-19 patients. I had a lot of help assembling this talk from two of my colleagues, Avery Tung, there's a red arrow pointing to him at the top of the slide, and Sajid Chahul, there's a red arrow pointing to him at the side. I guess one of the reasons why I was asked to give this talk is because shortly after COVID hit Chicago, I sent this email to Dan Brown saying that the most commonly seen in the ICUs is this upper respiratory tract infection that progresses to acute hypoxic respiratory failure. And you can see in the red, I bolded what I really want you to know, which is that these people appeared to have a viral pneumonitis more than ARDS, but it often progressed to ARDS. They had VQ mismatching from inflammation so severe that it verged on shunt physiology, and they were prone to collapse and associated shunt that did not improve with time because they didn't have hypoxic pulmonary vasoconstriction. And the second part of this was I speculated that non-invasive positive pressure ventilation, or BiPAP, in these patients allowed them to self-inflict a ventilator-associated lung injury. And we had a second phenotype early in the spring, and that was, the silent hypoxia, right? These people who I believed had a shower microemboli to their lungs and significant disease-associated inflammation, so that they got really hypoxemic. And it was obvious to me that there were overlaps. There were people that didn't fit neatly in one category or another. And of course, then in April, Marini and Gattinoni published this in JAMA. And they said there's this thing called COVID-associated respiratory distress syndrome, CARDS. And they said that there were really two phenotypes. The first was the L, which was basically this kind of high compliance phenomena that we saw with low lung weights and minimal responsiveness to PEEP. And then there was a type H, which was really perhaps much more classically ARDS. And they published this figure that said, here's type L and here's type H. And type L, they suggested that you be more liberal with tidal volumes and mechanical ventilation, and that you probably wouldn't need PEEPs more than 10. Whereas, the type H required higher PEEPs, maybe as high as 15. And that these people perhaps would benefit from low tidal volume ventilation. The other recommendation they made is wait until the patient's really significantly recovered before you engage in any efforts to separate them from mechanical ventilation. And of course, that generated a response in the literature, and a lot of my slides today are going to be extracted from other studies in the literature. And so this is a very nice paper published in the European Respiratory Journal by Boss and Sinha and Dixon. And they basically said we should be cautious about phenotyping this early. The argument against premature phenotyping is that our initial intuitions are often wrong. And in fact, the movement to evidence-based medicine worldwide has been predicated on this as an observation. Their related argument, number two, was that premature phenotyping can exacerbate our inherent susceptibility to cognitive biases. That is to say, we could get so wedded to our first impressions that we might actually not be able to see the disease for what it really is. The third argument was that it kind of might derail our efforts to kind of study this systematically, that we might not do randomized controlled trials or really look at our databases and collected data with kind of a rational or objective eye. And the final argument they had was that phenotyping could already perhaps introduce as much noise as it does signal. That is to say, if everybody's kind of sharing with everybody what their impressions are, it could be that what truth is out there is kind of drowned out by misperceptions. And they published this fabulous table in that paper demonstrating that, here's kind of the consequences of premature phenotyping and here's responsible phenotyping. And responsible phenotyping is really just a call for more systematic study and evaluation of the data in this syndrome, and who could object to that. But at the same time, those of us on the ground that needed to act had to act on the basis of the partial information that we had at the time. And so many of us bought into the premature phenotyping. With respect to ARDS itself, every time in medical literature you read about a consensus conference definition for something, generally speaking, that's a marker of a struggle to create consensus in that community. Additionally, almost always consensus conference definitions are modified for study purposes. That is to say, the number of studies that actually conform exactly to a consensus definition as written, is a handful at best. And of course, there's a growing belief that there are phenotypes of ARDS, and in fact, I've got two papers cited as references in this slide that kind of strongly support the idea that there are different phenotypes of ARDS. But interestingly, the vast majority of the prior art, say before 2016, didn't subclassify patients into subtypes of ARDS. And so we don't know how to manage, how to evaluate, how to treat any of the phenotypes of ARDS. That is to say, there's a huge opportunity here to go back and repeat many of the classic studies of ARDS, looking at a difference between phenotypes or even trying to discover phenotypes in those studies. And of course, ARDS as defined is incredibly heterogeneous. The question is COVID-19 ARDS heterogeneous? And the answer is yes and no. This is a fabulous table I took from the Massachusetts General website, their FLAIR series on COVID disease. And the point of this slide is to demonstrate, in fact, if you look at most of the larger series of patients who have been intubated and mechanically ventilated with COVID-19, that in fact, the compliance as measured on the ventilator is very low. That is to say, that kind of population of low compliance patients wasn't easily detected in New York, Boston, Atlanta, Vancouver, Seattle. This is a very nice paper published by some of the leaders in our field, Ferguson, Slutsky, among them, looking at data from Italy, Seattle, Amsterdam, New York, and once again demonstrating that these people required PEEP. They had low compliances. Here's the compliance figures. You can see the compliances are generally low. The best compliance is in this early data from Italy. After that, it's pretty poor, although it's actually not that bad in Amsterdam either. But once again, in this data, COVID is a lot like the rest of ARDS. And in fact, these authors kind of conclude by saying that, personalized lung protective mechanical ventilation reduces mortality and has become the mainstay treatment in ARDS. And that's absolutely true. And they said they strongly recommend adherence to evidence-based management informed by bedside physiology as resources permit. And of course, Martin Tobin published this in the American Journal of Respiratory Critical Care Medicine, saying many patients with COVID-19 are intubated because of hypoxemia. They exhibit little dyspnea or distress. Humans do not typically experience dyspnea until PO2 falls to 60 or lower. And he says, I was once a subject in an experiment probing the effect of hypoxemia on breathing. And my SAT was less than 80 for over an hour. And I was not really sensate to it. Now, I'll tell you, my own personal experience is exactly this. You can be impressively hypoxemic and relatively unperturbed by it. And of course, there have been a slew of studies in the literature. And so this is a paper by Dont, Derome, Brackle, Dubois, and Lambrecht, really talking about this idea of happy hypoxia, this silent cyanotic patients with COVID ARDS or COVID respiratory failure. And like I said, I believe that those patients were out there. And of course, Martin and Drs. Gibran and Laghi published this, which was, misconceptions about the pathophysiology of happy hypoxia and the implications for the management of ARDS, or of COVID ARDS. And then Tobin and Laghi and Gibran said, P-Siley is not justification for intubation in patients with ARDS. And, Crucis and his colleagues here published this, which was a physiologic approach. Now, I want to just kind of distinguish here, at the University of Chicago, one of our early strategies was to use high-flow nasal cannula in preference to non-invasive positive pressure ventilation, or BiPAP, in the management of patients with COVID-associated respiratory failure, with the idea being that, in fact, you give somebody a BiPAP machine and they may well self-inflict a lung injury, whereas if you put somebody on high-flow nasal cannula, they'll have only their respiratory muscles to recruit to inflict that injury. And so if you kind of look at the state of the art as it exists, right now, I think everybody would say you need to give these patients adequate oxygenation. You need to avoid patient self-inflicted lung injury. I think most people would say it doesn't matter what you think is going on with a patient. Probably the thing to do in anybody who's got COVID disease is, in fact, to go ahead and manage them with lung protective ventilation. And frankly, I think most of us would agree that you should go ahead and engage in a spontaneously breathing trial as soon as you think the patient's ready for it. This is some data from the University of Chicago, and you can see NIRS is non-invasive respiratory support. This is mostly high-flow nasal cannula. And you can see, very quickly, kind of reading through this slide, that we had significant success with what we call our prevent the vent strategy. That is to say, if we could, we supported you on BiPAP, or on high-flow nasal cannula for as long as we possibly could. And we had, significantly better hospital lengths of stays, and significantly better outcomes in general with lower mortality. The downside is the people who failed high-flow nasal cannula, who ended up getting intubated, they had a really high mortality. It was a bad thing to end up needing to be intubated if you had failed high-flow nasal cannula. And so overall, our outcome at the University of Chicago compared to the US in general, we had better mortality, better length of stay, much better discharge rate to home, and a much lower rate of intubation compared to other hospitals, once again, from resorting to high-flow nasal cannula. And why do I think that might have helped? Because once again, I think our patients didn't get a self-inflicted lung injury from non-invasive ventilation, and they didn't get a ventilator-associated lung injury from mechanical ventilation. COVID-19 ARDS is a unique opportunity to study ARDS arising from a viral pneumonitis. It's a subset of intrinsic ARDS, and it could become a or the model for viral pneumonitis in ARDS. And it's an unprecedented opportunity, particularly early in our era of COVID-19, right? In March and April and May in Chicago, it was a very homogeneous set of patients who had respiratory failure from COVID-19. One of the problems we've had since then is that COVID has become so prevalent that a lot of the patients in the hospital who have the diagnosis of COVID are in the hospital for something else, and they happen to have tested positive for COVID. And if they get ARDS, it probably isn't related to their COVID infection. So a lot of my trauma patients have COVID. But if they get ARDS, it's probably a consequence of their trauma, not their COVID infection. And so we need to be very careful as we study this to look at patients who are in the hospital for COVID-associated respiratory failure. People are out there looking for markers or biomarkers for COVID-19 associated respiratory failure. This reference here is a pointer to one of them. As you think about it, what about the bedside physiology has really made practitioners deviate from the guidelines, right? And so here's a very nice kind of summary, once again, from the MGH websites, looking at the number of patients and kind of the autopsy findings or postmortem biopsy findings in these patients. And once again, I'm just going to go ahead and point out that there's a big difference between people who are in the hospital with COVID, who then develop ARDS, versus people admitted to the hospital for COVID and develop ARDS. And in the last little while, we've had some data to kind of help us understand that. The University of Chicago data from our patients who died from COVID was boggy lungs, patchy to diffuse consolidation parenchyma, extracellular viral inclusions, but really important, diffuse alveolar damage with alveolar hemorrhage and vascular thrombosis. What's the peer-reviewed literature say? This is a paper recently published in the New England Journal of Medicine. This is a micrograph of microthrombi in the pulmonary capillaries, atypical of ARDS. This is electron micrographs of microvascular alterations in the lungs, mostly kind of actually new blood vessel formation, what they call angiogenesis features or angiogenic features in patients with COVID-associated ARDS. And here's a slide that compares COVID to influenza to controls. And you can see that COVID ARDS is different than influenza ARDS by all of these metrics and in a non-trivial way. It's very important because, in fact, this is clear evidence that it is different, that it's worthy of study. It may be a subtype or a phenotype of ARDS, and it might be a very useful model for us to extract data about how to manage viral pneumonitis. And if you kind of read the conclusions of this paper, they say there are three distinctive features of COVID ARDS. The first was that there was significant endothelial injury. The second was that there was widespread vascular thrombosis with microangiopathy and occlusion of alveolar capillaries. And the third was, once again, this kind of angiogenesis that was occurring in these lung specimens. So the New England Journal of Medicine pathology might explain happy hypoxia is in fact a syndrome in which patients have predominantly microthrombi as the driver of their hypoxia. It's very clear that COVID-19 ARDS is different from influenza ARDS. And I would argue that COVID-19 does have a distinctive phenotype. It may not require much in the way present, overtly different clinical management than patients with ARDS. When in doubt, manage COVID-19 ARDS with lung protective ventilation and least PEEP. Consider high-flow nasal cannula and self-proning as an alternative to non-invasive ventilation, which may or may not cause patient self-inflicted lung injury. Don't wait too long to intubate these people. And seize this opportunity to learn as much as we can systemically with an open mind about how to evaluate and manage these patients. And with that, I'm done. Thank you very much.
Over to Dr. Gallo Di Maria, who will speak to a different type of lung disease, or at least initiation of lung disease, vaping-associated respiratory distress syndrome. Please.
This is different in the sense that it can present in so many ways, and I'm going to show you some of the ways that it can present. I have nothing to disclose. Just I want to start by saying that we don't know a whole lot about EVALI yet, so I tried to find as much as I could, and I'm hoping I can share that with you today. So definitions, we have to start by definition. So vaping is the process of inhaling an aerosol that is created by heating a liquid or wax containing various substances. So far, all the e-cigarettes all the patients who had EVALI had cannabinoids, some type of flavoring found in their BAL, nicotine, additives like vitamin E, and we're going to talk about it. And EVALI was the definition used by intensivists, pulmonologists, and internal medicine docs around the world to describe this particular injury that results from the use of e-cigarettes. And I confess that before I wrote this particular paper with one of our former fellows, I did not know what an e-cigarette looked like. So that's why we decided to do some research, and we did this drawing together. So I decided to put it here so in case people don't know what it looks like. But basically, the heating element atomizer is going to heat the substance that comes in those little cartridges that patients can buy in regular tobacco stores, but also illegally. They're sold anywhere, and most of the patients that have injury have smoked those cartridges that are not legal. So epidemiology, again, since COVID hit, the CDC has not been updated in terms of cases, but the first outbreak happened in March of 2019. Most cases were around here, Mayo Clinic in Wisconsin, and so far, 2,800 cases were reported to the CDC with 68 deaths, so not a high mortality rate, but more and more cases were reported since March of 2019. Most patients are men and younger than 35, but there were reports of cases in patients who were in their late 70s, early 80s as well. The beginning of the outbreak was associated with a thought that using e-cigarettes would help people stop smoking. which so far has not seemed to pan out, but that was the correlation of that first outbreak. And asthma has been associated with worse cases of E-valley, but obesity has been associated with most of the deaths that happened. So, like I said, a lot of unknowns. The real pathogenesis at the moment is still unknown. There were several reports and case series that were published, and in pathology that was found pneumonitis, diffuse alveolar damage, organizing, eosinophilic pneumonia, but not a single pathogenesis has been described to kind of like put all of the cases together. The patients that underwent bronchoalveolar lavage in severe cases, most of them had THC and vitamin E acetate found in their BAL, and their BAL cellularity was neutrophilic predominant, and a lot of questions still being trying to be answered with research, seeing if it's the wax preparation of THC that is put in that cartridge that causes lung damage by heating, or if it's the product that is in the cartridge, and when they're heated, they then kind of like become new toxic agents. So again, a lot of unknowns. We just know that vaping does cause lung injury. Diagnosis, most important thing is history. Just to illustrate, at the beginning of the pandemic, we had a case that presented with diffuse lung injury, and we were really convinced it was COVID. The patient was tested 7 times, and when he finally was extubated and could talk to us, he has been vaping way more than his normal in the previous 3 or 4 months. And it was all vaping. He got steroids and he's doing much better. But in the case of vaping, the history is the most important thing. But for diagnosis, BAL can help if you find THC and vitamin E, but if the BAL happens more than 72 hours after the patient had the lung injury, you might not find them anymore. And neutrophilic predominance. Some patients will present with acute eosinophilic pneumonia from vaping, and those patients might have eosinophilic predominance. So again, no consensus in BAL cellular finding. And so as of today, the diagnosis is of exclusion. So excluding regular bacterial infections, regular viral infections, rare fungal infections, and history of vaping, obviously. Uncertain utility of biomarkers. There are several studies that are happening around the country, at least that I know of, checking CRP, if the level of CRP would correlate with the use of vaping, if procalcitonin can have a say in ruling in or ruling out vaping is also going on, but so far no definitive utility of biomarkers. And as I'm going to show you in the next few slides, the radiological findings are extremely variable. So the first one, the most common one, can you see my arrow? So most common presentation in terms of radiographic findings, CT findings, is this one, which is hypersensitive pneumonitis. You can see ground glass opacities. There are more predominant in the lower lobes with mosaic attenuation. In the upper lobes, you can see that there are like some areas of normal lung. So acute hypersensitive pneumonitis is the most common presentation. You can also have patients presenting with alveolar hemorrhage that you can see that is asymmetric, and areas of hemorrhage around the vessels and that have a certain degree of subpleural sparing. Can also see, like I mentioned before, acute eosinophilic pneumonia with dense consolidation in the peribronchial distribution with bilateral pleural effusion. This patient in particular had a BAL with eosinophilic predominance, and this patient had 39% of peripheral eosinophils as well. Patients can also present with regular ARDS. This was a young patient who presented with bilateral fluffy infiltrates initially, and this is the fibrotic phase of his disease. And you can see that symmetric distribution, acute, regular, diffuse lung injury, acute lung injury, and can also present, last but not least, can also present as organizing pneumonia, where you're going to see symmetrical distribution also, but with areas of ground glass consolidation associated with dense consolidation with clear subpleural squaring. All patients for treatment, best supportive care, steroids really work. These patients do really well with steroids, and they usually have complete resolution of their radiological findings and symptoms. And obviously the most important thing is vaping cessation, obviously. And I thought that we were going to do questions after each presentation, but my email is here and my Twitter handle is here as well. I'm a big fan of Twitter, so come find me on Twitter and interact with me on Twitter. So.
Conclude our last session with Dr. Laurent Brochard, who will be speaking about when is the right time for spontaneous breathing trials.
Okay, thank you. Thanks again for the invitation. It's so I gave a talk later today, and it's really fascinating to have a connection all around the world. So thanks again. So I'm going to discuss this issue of the timing of the spontaneous breathing trial, which I think is important and complicated, but fascinating. So I'm working with a number of companies to get research grants or mostly equipment. They are listed here. And maybe a brief overview of what are the problems with weaning from mechanical ventilation. And in terms of the magnitude of the problem, I would say weaning is important because it concerns all patients on the ventilator. It deals with very different types of issue. And therefore, to try to make a kind of schema of what are the different types of problem in weaning, we came with this definition of simple weaning, difficult weaning, and prolonged weaning. And the idea was to describe different types of problem and different types of patients. And for instance, in this study, which was a multi-center observational trial in France and some countries in Europe, more than 2,700 patients, we look at patients who were separated from the vent from in 24 hours, who took between 24 and 1 week to be separated, or who were still on the vent after 7 days. And I'll come back to this data, but what we found was that the majority of patients are here in group 1, which means the patients who have weaning terminated within 24 hours. And we could say, okay, these are the patients with no problem for weaning. And I would say, I'm not sure, because if there are so many patients who can be separated very easily, maybe they have been tested already too late, because they could have been separated 1 day, 2 days, 3 days earlier, I don't know. So that's a kind of questions we are going to ask. And on the other hand, when we look at patients who failed their first separation attempt, we observe that the probability of hospital death was increasing daily. Maybe there is a kind of plateau in the first week, but you see, if you're still on the vent after several weaning attempts, after 10 days, the mortality rate is close to ARDS. So it's of course no direct relationship, but maybe there is a good rationale to say we should try to separate the patient as early as possible. And the issue of the SBT, which is a test, the spontaneous breathing trial, is to identify patients. And the question is, why do we need to actively identify patients? Because we could wait until the patients look really good or ask to be extubated. So this comes really from this seminal study by Wes Ely in 1996. They randomized patients to an intervention and compared to their control approach. And the intervention was very straightforward. They say, let's have a very simple daily screening of respiratory function, let's say, kind of screening which can be done in 5 minutes. So is the PaO2, FiO2 okay? Is the PEEP level relatively low? And of course, you could discuss all these thresholds. Is the patient able to cough when you suction? So very, very simple criteria. Is the ratio of frequency to tidal volume, which is called the rapid shallow breathing index, is it below 100 or 105? And I will come back to this specific aspect, which has been later debated. And is the patient off vasopressor, off sedative? And if you check all these boxes, then the patient must be submitted to spontaneous breathing trial. And then you notify the physician of the result if successful, saying, well, the patient passed the SBT, it means the patient has 85% of chance of being extubated successfully. And this resulted in a very spectacular reduction in the duration of ventilation. You see here a patient receiving mechanical ventilation, for instance, after 4 days, it's maybe less than 15% here, whereas it's close to still 50% in the control group. And there was no complication, no reintubation, no more tracheostomy, etc. So very interesting approach, saying we need to screen systematically very simple criteria. Don't look at hemoglobin, temperature, phosphor, I don't know what. So you just go ahead. Let's try to find some arguments why we need to do that. So in the control group in this study, SIMV was used as the preferred method to ventilate and separate patients from the vent. That's interesting because the randomized trial done before had already shown that SIMV was the worst method to separate patients from the vent. And one could say, why? Why is SIMV specifically bad? And I don't think it's bad by itself for the patient, but this is a very nice physiological study, which this is a recordings of diaphragm EMG, sternocleidomastoid muscle, the airway pressure, and the esophageal pressure. So 3 indexes of respiratory muscle activity, and one which is what happens on the vent. So this is the one you see on the vent. You have assisted breath and spontaneous breath. And when you see that, you say, oh yeah, maybe the patient is doing half of the work. But when you look at the patient's tracings, it's impossible to differentiate the spontaneous breath from the assisted breath. So in other terms, what SIMV is doing is masking the clinician about what the patient is doing. So this is, in general, what mechanical ventilation do. With mechanical ventilation, whether it's SIMV, assist control, pressure support, it becomes very difficult to know what the patient is capable of. And that's why this is an argument to directly test the patient. Another argument I'd like to show is the result of the smart care weaning technique. I have a conflict of interest here because I'm one of the inventors of this technique, but I have no financial conflict. And we made something quite simple, which was to decrease automatically the level of pressure support, provided that the respiratory rate is okay, the PCO2 does not go too high, etc. And when a minimal level of pressure support was reached, there was an incentive on the screen saying your patient can be separated from the vent. So very simple. I know many people don't like to use it, but the results are quite positive when you go to all the different trials and you do meta-analysis. This is a duration of weaning, but you have the same for duration of ICU stay. It significantly reduced the duration of the length of ventilation. And the main reason, and I think it has been misunderstood by many people, it's not because it has a magic physiological, like a therapy for the patient. It's just because it does the work of systematic screening and going down on the ventilator, which we don't have time to do very often. So it's another argument to say maybe having something systematic and it will separate many patients earlier from the ventilator. So how can we identify patients capable of breathing spontaneously? So I discussed this very general criteria that you can use in your ICU. But in addition, you can have another tool which can really be helpful, which is called the Rapid Shallow Breathing Index. And this is illustrated here. This is the tracings from a patient who is separated from the vent. So this is the respiratory rate going up, the tidal volume going down. And after 25 minutes, the patient was in clinical respiratory distress. So he was put back on the vent. And it was shown repeatedly that patients who failed the winning trial often have a high respiratory rate and a low tidal volume. So if you make the ratio of frequency over tidal volume, you have a high value, which, for instance, here close to 40 and below 300, that would make a value close to 200. And the idea is that the information of the rapid shallow breathing can be obtained just after 1 or 2 minutes. You don't need to wait for the patient being struggling, using accessory muscles, sweating. You just know immediately. So the idea is to say, I have no idea whether my patient is capable of being separated. So I do this test. This test is very high. So I stop and I will repeat it tomorrow. Or this test is okay or borderline around 100. Well, maybe it's worth doing the full spontaneous breathing trial. So at that point, it's necessary to stop a little bit and think of when you use a test, you need to take into account the pre-test probability. So what does it mean for winning? Well, it means that if you test, this is a series of studies which use the F over VT. And you see the initial study by Young and Tobin, their probability of success was close to 50%. How do they know the probability of success? They just look at the result of the spontaneous breathing trial, right? So 50% of patients succeeded and 45% failed. And they found that in this circumstance, this is super useful because you don't know, you're completely uncertain, and doing this test tells you, oh, yeah, you can try, or no, it's not necessary, you can wait for the next SBT. But look at some of the studies on the right. They tested, they used this test when the pretest probability was close to 90%. In which case it has no sense because you know that 90% of your patients will be successful. So you don't need the screening test like the F over VT. You may just have false negative, if you wish, because some patients will not tolerate. So you just need to extubate these patients. And unfortunately, this notion of the pretest probability has been forgotten. This is a recent trial. I'm not going to discuss the details of the trial, but they compare the SBT with the TPs or with pressure support. But look at the success rate. It was between 85 and 92%, which means these patients were already ready for extubation. And so I would say two things about this study. I think the interpretation of the test need to take into account this pretest probability. I don't think TPs of 2 hours makes any sense when you know that 90% of the patient will be extubated. And second, why do people wait so long for testing their patients? So let's finish quickly with the last part. Is there an impact of delaying this identification? Well, we think so, but that's difficult to know. let me show you very briefly some preliminary results from the WinSafe study, which is an observational multi-center international study coming from different countries in the world. We found the same type of distribution of the group 1, 24 hours, group 2 take less than 1 week, and group 3 patients who are still on the vent after 3 days. These groups are very different. If you just look at the first line, this is the percentage of tracheostomized patients, so very different outcome. And interestingly, most of the patients were at their first separation attempt when they were on pressure support, but many at their first separation attempt when they were on already controlled ventilation, which is maybe a different approach. So do we need to wait until the patient is on pressure support to start the first separation attempt? We tried to address this question, and these are very preliminary results, and we said, is it an impact on the duration of time between the first winning criteria, the one which I described, very general winning criteria, and the first separation attempt? It should be the same for all patients, right? But there was a significant difference, and there was significantly patients with longer time in group 2 and group 3, which could be interpreted as the fact that if you wait to start the first separation attempt, you impose a certain delay on the final time for extubation. So preliminary result, we need more data, but a very important clinical question. So I will just conclude, because I think it's time, saying that delaying screening may impact the duration of winning and patient's outcome. Thank you very much, and happy to answer any question.
I'll start with Dr. Burchard.
Yeah.
So how do you manage in your institution to incorporate spontaneous awakening trials with your spontaneous breathing trials successfully?
Well, that's, I have to say, this is, I would say, the most complicated part, and I would not say we are completely successful with that. My feeling is that okay, let's say I'm working at a hospital called St. Michael's Hospital. It's historically a Catholic hospital in the poor part of the city. It's important because the type of patients we have in the ICU are drug user, patients with alcohol problems, homeless patients. And I have to say that I tell the nurse, you should stop the sedation, but then the patients become agitated, difficult to, that's much more difficult to control in my real life than on the paper. So I think this part, so whether it's only because of their habits or some kind of delirium in the ICU, and but that's more difficult to manage.
Can I ask Dr. O'Connell a question?
Here I am.
Do you think your patients who failed the high flow were sicker to begin with than the ones that didn't fail, or no?
You know, I don't think so. I think, honestly, although we didn't randomize people, I think, you know, we intubated, you know, people according to kind of the guidance that had come from Italy and Europe early on. And then we said, let's just do the high flow nasal cannula like we always do. And so I think they were the same. And I mean, unfortunately, I don't think we moved the mortality marker in our smaller series with the high flow nasal cannula. But what we did do is we avoided sedating people. We avoided the complications of mechanical ventilation. We reduced the ICU length of stay by a little bit. You know, our patients were able to do OT, PT, you know, day one. There was never an issue with enteral nutrition. They were self-proning, so there were no positioning injuries. You know, so for myself, I don't know if I saved any lives. I will tell you, I think I made a lot of hospital capacity.
Because I have the same feeling here, because I have been staffing our COVID ICU, and I also feel like, I don't know how you feel, but I feel like the ROC score is not super helpful for these patients either, like to predict who is gonna, for particularly in COVID. But I feel the same way as you do. Like, I feel like we rehabbed these people earlier, but I'm not sure we are moving the mortality needle that much. But I have a feeling that the patients who failed high flow were a little sicker in the sense like another organ was failed. So.
Well, I think that they progressed. I think those are the people who progressed, right? And as a group, as a consequence, they had higher mortality. So I think failing high flow nasal cannula. Now, for myself, on average, they got intubated on day 5. I think, my colleagues have said if we had to do this over again, when the sun rises on day 4, that's when I would choose to intubate these people because, it was a physiologic crisis to institute mechanical ventilation on day 5 in these people. But, for myself, in this pandemic, it's incredibly important to not discount interventions that reduce hospital length of stay. So, for example, we were a remdesivir trial center, right? And, remdesivir shortens the length of disease from 15 days to 10 days. It shortens the hospital length of stay by 30% or so. It was like somebody gave me 30% more beds in my hospital. It was, it was a gift from God.
Alice, Dr. Gallo, you speak to steroid administration for vaping-induced lung injury.
Yep.
Can you speak a little bit, and you also say it's basically a diagnosis of exclusion as well. So when, what dose, how long, what are your thoughts, or what does the available literature suggest?
That's a fabulous question, because the available literature went from a gram for 3 days to 60 and a taper, quick taper. But from the cases we've seen, probably like taper that is equivalent to acute hypersensitive pneumonitis. So 40 for 2 weeks, 30 for 2 weeks, and down by 10 every 2 weeks. Has been shown to do that the patients do really well, and start as soon as you rule out that is an acute bacterial infection. So if you got your MRSA swab, for example, and that was negative, that the likelihood that is a MRSA pneumonia is very low. And if you did a BAL or if you did tracheoaspirate and those are negative, start the steroids as soon as you get those. And if the suspicion is really high, like someone tells you, yeah, my son or my husband or my wife, my daughter, they vape, then start as soon as you know that too.
I have a question that kind of combines Dr. O'Connor and Dr. Burchard's talks. Did you either of you conduct spontaneous breathing trials differently in your COVID-19 patients?
Mm-hmm.
Nope. Every day.
You asked me about the spontaneous awakening trials. This has been worse. We have been given more sedation, and I understand why, because initially we didn't have the good rooms, and so we wanted to. I think people wanted to keep the patient as long as possible, completely stable and quiet. And I think this is part of the reason we have seen such long duration of mechanical ventilation. Especially you have the patient in the room, you close the door, you have maybe the lines going under the door. You don't want the patient to, you don't want to take any risks. So this has complicated the issue of sedation and spontaneous breathing trial. And then the second question we had repeatedly was about the cuff leak test. We do a cuff leak test, but we don't know very well what to do with it, right? And we were more concerned because of we had 2 reintubation early on, and then we started to learn that there was maybe an higher rate of laryngeal problems after extubation in these patients. So we have been a bit more careful and maybe giving extra steroids when we were inducted with the cuff leak test. So this has been the 2 things which were a bit different.
What kind of tracheal problems are you seeing?
So I've been following the literature on that, and there have been description of massive tracheal injury and laryngeal injury. It's very difficult to know whether the incidence is different from before.
Yeah. Yeah.
Some reports, very few, reported that positive viral culture, so which could suggest that because you have a receptor there, you have more vascular involvement, but I'm not sure it's very strong. So I think this is something to look at more closely. I'm just in between, you know, saying, well, there may be some evidence about higher risk and we should be careful for our patients, but the evidence is not very strong.
I have a question for Dr. O'Connor, and I appreciate the different phenotypes that exist, but from a practical and you know how that leads down for areas of investigation and potential treatments, but from a practical standpoint, as a clinician, other than lung protective ventilation, does it matter to you?
Well, you know, what a good question. So for myself, the short answer is I don't know the answer to your question. The slightly longer answer is, you know, I think many of our colleagues have been willing to accept larger tidal volumes in patients as long as the plateau pressures were acceptable or met ARDS-NET criteria. And I think we also tended to kind of be cortically blind to large tidal volumes in patients who are on non-invasive positive pressure ventilation. And I think that this pandemic has really made us call into question both of those. I mean, I think increasingly I'm of the opinion that we should just limit the tidal volume in these people and, you know, only turn it down if the plateau pressure is high, not let it be higher if the plateau pressure seems to be in some very acceptable range. Similarly, you know, for myself, it's just driving me further away from non-invasive positive pressure ventilation for people with ARDS. You got high pressure pulmonary edema, I'll try some BiPAP on you. But, you know, for COVID-19, I think I'm going to stick with the high flow nasal cannula. Like I said, sun rises on day 4. I think my colleagues are going to intubate you.
No, I agree. Just to mention the point about allowing larger tidal volumes for some of the patients with relatively good compliance. I think it's the same question for ARDS, honestly. And it has been, you know, pushed out because of the description by Gattinoni. And I think part of the response of that is the driving pressure, which the driving pressure is really the ratio of the volume you give to the capacity of the lung. And so in the case you have still a very low, acceptable, reasonable driving pressure, accepting somewhat higher tidal volume makes sense. We are doing a study looking at the database from different trials with Yuan Golliger from Toronto, and our findings suggest it's absolutely fine to accept, or let's say that the risk of having larger tidal volumes in this case is minimal or does not exist. So.
Well, we finished, I believe we were to finish at 12, at the bottom of the hour. I forget what format we're on here. I'll say bottom of the hour. And I would like to thank all the participants for attending, and our presenters. Very much appreciate your insights today. And depending upon where you are in the world, have a good start of the day if you're down in Australia, or wrap it up if you are in Europe perhaps. And thank you all again.